Hi, I'm Krista, and let's face it, clients in the hospital do a lot of laying in bed, and we're not worried about them being bored, we're worried about pressure injuries. So let's get under the skin today and talk about all the must-knows about wounds and hygiene for the NCLEX. So let's start with the integumentary system, the skin. It's the largest organ in the body and it protects our muscles and bones. It's also our first line of defense against microorganisms. Also, it can help us regulate temperature with things like perspiration and prevent moisture loss. It also senses pain, pressure, and temperature to let us know if something's wrong. So when that skin barrier breaks down, we're worried about a top concern for our hospitalized clients, and that is pressure injuries. So this is a nursing sensitive indicator, so good nursing care can prevent them. A pressure injury is an injury from prolonged pressure, friction, and/or shear. So prolonged pressure happens on these bony prominences like the sacrum and heels, and that causes that bone to put pressure on the skin, decrease perfusion, and lead to injury. Then we see friction. That's from rubbing against a surface like a bed or a wheelchair, and that causes superficial skin damage. Then we see shear. That's from something like sliding down a bed, where the bottom tissues are going in one direction and the top layer of tissues are going another, and that causes tissue damage. The NCLEX loves to test who's at highest risk for a pressure injury, so pay attention to these first 3 star points. Those with increased moisture exposure are those incontinent clients. They are at high risk because their skin gets soft from moisture exposure, leading to injury. Then our decreased mobility clients, like those with stroke or postoperative clients, they are not moving as much, so they can have prolonged pressure over these bony prominences like the sacrum. Then those with decreased sensory perception, like those with neuropathy or paralysis, remember they can't sense pain or pressure, so they're definitely at risk for an injury. Then we have those with decreased nutrition or perfusion, like our diabetic clients. They have decreased perfusion, so there's not as much nutrients getting to that skin, and it can cause that skin to get fragile and weak. So what do we do with these clients? We assess their risk for a pressure injury, and we assess their skin. So we use a Braden scale to assess their pressure injury risk, using factors like mobility and nutrition to score them. A lower score equals a higher risk. So any score less than 18 is at risk for a pressure injury. Remember, we assess the skin and the Braden scale at admission and at regular intervals throughout their stay in the hospital. Then we assess bony prominences and under medical devices because this is where pressure injuries tend to happen. If an injury is found, we do not massage the reddened areas. That can cause increased tissue damage. Instead, we need to document and determine the stage of the pressure injury. So for pressure injuries, I want you to think we start at the top layer of the skin and we get deeper and deeper with each stage. So for stage 1, think the skin is intact. We see non-blanchable redness like this, so it's red, and when we push on it, it stays red. Remember, it's okay to push on skin to test if it's blanchable or not. It's not okay to massage reddened areas. That's what causes tissue damage. Stage 2, we're seeing partial thickness loss. So we're taking off that top layer of skin and the skin is no longer intact. Then we see a shallow wound or blister like we see here. So now we're at stage 3, we're even deeper to the subcutaneous tissue. We see full thickness loss with visible subcutaneous tissue like we see here. So at stage 4, we're at the deepest level and we're seeing full thickness loss with exposed muscle, tendon, or bone like we see here. Now we're at instageable pressure injuries where we see full thickness loss, but we see slough, which is that stringy yellow substance, or eschar, which is that necrotic tissue. It's in the way of that wound bed and we can't stage it. Therefore, this wound must be debrided before we can stage it. So for our deep tissue pressure injuries, it's like a giant bruise from prolonged severe pressure. We see it's non-blanchable with dark discoloration, usually red or purplish, and it feels spongy, and it looks something like this. So our NCLEX quick check, we see in what stage of pressure injury is the skin intact with non-blanchable redness. Remember, that's at the surface of the skin when it's intact. It's a stage 1. Then we see in what stage is a full thickness loss with visible subcutaneous tissue. Remember, that's not that second stage, but that's down to the 3rd stage, that subcutaneous level. So that's a stage 3. So pressure injuries are a huge concern for our clients. So our number 1 priority is to prevent them. We need to offload pressure by turning, tilting, and lifting those clients. So we need to turn our clients every 2 hours, tilt at a 30-degree lateral angle. That can help decrease pressure, like we can see here, off that sacrum and other bony prominences. Then we also need to lift them. We need to lift that head of bed 30 degrees, but no higher, because lifting it higher can put pressure on that sacrum and cause them to slide down the bed, and that will cause that shearing. So using pillows, wedges, or devices to lift body parts, like we see here, floating the heels, decreases pressure on those bony prominences and can decrease that risk of injury. Then avoid donut cushions. The NCLEX could ask you, put a donut cushion under a seated client. That sounds great. No, because that can increase pressure in that pelvic area that can decrease perfusion. That leads to a pressure injury. Then use lifting devices. If we move our clients, use a draw sheet or a mechanical lift. That can prevent dragging or pulling, which can lead to that friction and shear. Then we need to protect that skin. For our incontinent clients, we need to prevent any kind of moisture from getting to that skin. How do we do that? Use absorbent pads and barrier creams to protect that skin. Then we need to encourage increased protein and fluids, because that can promote skin repair. So our next NCLEX quick check: how high should the head of bed be for a client at risk for a pressure injury? No higher than 30 degrees. Remember, anything higher can cause increased pressure on that sacrum and sliding down the bed that leads to shear. How often should the nurse turn immobile clients? Remember, turning is every 2 hours. If prevention fails and a wound does develop, we need to provide optimal wound care to promote healing. So we need to pre-medicate our clients with oral analgesics 30 to 45 minutes before care, because that can ensure that analgesic is working at peak effectiveness during that painful wound care. We need to don gloves and clean from the center to the edges, the cleanest to the dirtiest part of the wound. And we need to use sterile saline. The NCLEX may try to trick you and say, we should clean with hydrogen peroxide. That sounds great. Definitely not. Povidone, iodine, and hydrogen peroxide are cytotoxic agents we need to avoid, because they can kill healthy cells and delay wound healing. Then we need to report signs of infection like purulent drainage or foul odor. If there is a suspected infection, we need to prepare for wound culture to identify the organism causing it, and we need to give antibiotics to treat it. Our next quick check: how long before wound care should the nurse administer oral analgesics? That's 30 to 45 minutes before, to ensure it's working at peak effectiveness during that painful wound care. The nurse should clean the wound with hydrogen peroxide. True or false? Definitely false. That's a cytotoxic agent. Instead, use sterile saline. So from dirty wounds to clean skin, we need to protect that skin barrier by promoting good hygiene. So when bathing, we always need to provide privacy by draping parts of the skin that we are not bathing. Then we need to wash from clean to dirty. Remember, we don't want anything dirty getting into a clean area. Then use warm, not hot water that can injure the skin. Pat dry at skin folds, because any moisture between skin folds can breed bacteria and fungus. So for perineal care, we follow that clean to dirty principle. Remember, for females, separate the labia and clean front to back. That prevents those urinary tract infections. Then for our males, we need to retract the foreskin, clean it in a circular motion from the center outwards, and return foreskin when done to prevent constriction of the area. Now down to the feet. We need to trim nails straight across to prevent ingrown toenails. Then we do not apply lotion between the toes. Remember, that harbors that bacteria and fungal growth. Then specialized care is needed for clients at risk for foot injury, like our diabetic clients or those with peripheral vascular disease. For these clients, we do not soak the feet, because remember, moisture can make the skin fragile. Then we need a healthcare provider order to trim the nails, because they're increased risk for foot injury. So for oral care, we always need to put our clients in a semi-Fowler's position to prevent aspiration. For our ventilated clients, we need to use chlorhexidine, because that can prevent ventilator-associated pneumonia. So our next quick check: should the nurse wash from dirty to clean or clean to dirty? Definitely clean to dirty. We don't want to put anything dirty in a clean area. Then the nurse should not soak the feet of clients with diabetes. True or false? Definitely true. Remember, they're at more risk for foot injury, so we do not soak their feet. So caring for the living means protecting that skin. But even after death, we need to continue to provide respectful care to these clients. We need to support and respect religion and culture for our client and their family. We need to connect them with the chaplain if they want it, and allow them time with the body. Then we need to ask family if they want to help with postmortem care. This can make them feel connected to their loved one. Then we need to position the body supine with the head on a pillow. That can help prevent discoloration in the face that happens after death. Then we need to clean that body, cover it with a sheet, and apply ID tags for transport. Notify that organ donation agency if they are an organ donor. Last quick check. Are family members allowed to assist with postmortem care? Definitely. That can help them feel connected to their loved one. Now you know how to master wounds and hygiene on the NCLEX.